Welcome to the Riverbend Awareness Project.
The views and opinions expressed in this podcast episode are solely those of the individuals participating and do not necessarily reflect the views or opinions of Riverbend Media Group or the Riverbend Awareness Project, its affiliates, or its employees. It is important to note that the discussion presented is for informational purposes only and should not be construed as medical advice. Listeners are encouraged to consult with qualified healthcare professionals for any medical concerns or decisions. The Riverbend Awareness Project is a product of Riverbend Media Group.
Welcome to the Riverbend Awareness Project. We are so excited to have Jim Jarvie and Anna Shackleford from Idaho Falls Community Hospital. Jim is the time-sensitive emergency manager, and Anna is the stroke STEMI performance improvement coordinator, and they're here to talk to us about stroke awareness.
So first off, so we're all on the same page, can you please just tell us a little bit about what exactly is a stroke?
So a stroke is basically when blood supply to the brain is interrupted. And it can either be by a clot where it's blocked, called an ischemic stroke, or from a blood vessel rupturing, which is a hemorrhagic stroke. So both of those, the damage is caused because that part of the brain that those blood vessels feed aren't getting oxygen and nutrients. And so the brain cells start dying pretty quickly. So those are the two types of stroke. And then there's also a transient ischemic attack. People call them a mini stroke. A person will have stroke symptoms, but they'll go away pretty quickly, usually within 24 hours, a lot of times less than that. But it's also called a warning stroke. So if somebody does have, a mini stroke or a TIA, they should seek help because there's a high chance of that person actually having a stroke, like within 90 days.
Is there a way that someone will feel kind of after a mini stroke or during that they can kind of think, I probably should go to my doctor just in case and make sure that I didn't just have a mini stroke, or see if I did and how to get that treated?
So with a mini stroke, a lot of people will have the same symptoms as a stroke.
Okay.
And Jim is going to talk about fast, but those are the symptoms they look for. And like I said, they'll have them for a little bit and they'll go away. So possibly there was a little clot that did a little blockage, but it was able to finally, get dissolved by itself or whatever. So the symptoms don't last.
So Jim, would you like to tell us a little bit more about the FAST acronym?
Yeah, so you have the FAST acronym, and I'm actually going to go with BFAST. Because there's some other symptoms, depending on where the blockage is or where in the brain is being affected, symptoms can be different. So the classical symptoms that kind of fast go through are facial weakness. You might see that one side of their lips drooping down, drooling. They can't close the eye on that side. It kind of gets flat down one side of the face. And so you may see that. You can ask them to smile. One side of the mouth goes up, the other doesn't. That's one of the ways you can look at. So F is facial. And A is for arm. And what we generally do is have them put their arms out in front of them. And if they can hold their arms up, but if one of them's drifting or they can't lift it up, or they lift it up and as soon as it gets there, it just kind of falls down. So arm weakness also goes along with leg weakness on that same side. Okay. We do, a lot of times when we see it, you'll see the face, the arm, and the leg all together at the same time. It may be just a little weakness, or it may be just profound. They can't move that side of their body. And S is for speech. So people can have slurred speech. They can have different types of aphasia, expressive aphasia, receptive aphasia. They may not understand what's being asked of them, or they completely understand what's being asked for them, but the words that they speak, they know what they want to say, the words that they're saying don't match. They're not able to get that out. Also with that, if they're having trouble swallowing, that kind of goes hand in hand. Say they grabbed and tried to take a drink of water and they start coughing and choking. Okay, so that all kind of goes together with the speech. T, we say, is time. Time is of the essence. If you have these symptoms, you call 911. You shouldn't get in your car and have somebody drive you or try and drive yourself. By activating 911, the ambulance service can initiate some of those treatments early to help kind of minimize some of the things that are happening. They also call the hospital ahead of time, so the hospital stroke team's there when the patient gets there. And all of that is to reduce the amount of time. Now, I said be fast, so I wanted to add in balance, okay? So people will stand up and they're off balance, or they're extremely dizzy. You watch them walk and they're drifting to one side, they're leaning to that side, or bumping into the wall on one side or the other. So that balance effect. And then eyes. Eyes, you have trouble, all of a sudden you can't see out of one eye. You can only see from your nose everything to the left, but you can't see things to the right. When you're looking here, it's just completely black on this side, or that side, or up here, or down here. And so we use all of those different symptoms because you never know what part of the brain's being affected, and the symptoms help us with that.
Are there less common signs, like beyond those, that could also indicate a stroke or a mini stroke's happening?
So when Jim was talking about the be fast, a lot of times might present as confusion is a big one, because the person either can't speak or can't find the words, or depending on where in the brain it happened, they don't understand. Their brain is just not letting them process what's coming in. So a lot of times, people might think they're confused. Other milder symptoms you might see is, especially in women, is fatigue. They'll have like a generalized weakness. They can have nausea, vomiting. And women can still have all the other symptoms too with the fast, but those are some milder ones that sometimes we don't really think about.
Along with the weakness, numbness and tingling. So it may be numbness and tingling on one side and not as much weakness. But again, you see it from the face to the arm to the leg.
Is it always on one side? Not like a specific side, but can you have it on both sides, or is it only just one or the other side of the...
So it's usually just on one side.
Okay.
Very, very rarely, depending on where it is in the brain, like in the brainstem, sometimes it might involve both, but mostly it's one side.
When we get into the risk factors, some of those we'll call what's called a shower type effect. And that can have where multiple blood clots hit. And as they go up, they can hit both sides. And then you would have symptoms on both sides. Generally, if it's just being blocked on one side, so if it's blocked on my right side, my symptoms are going to be on my left side. Vice versa.
Okay. We could talk about that now, right? Risk factors.
Yeah, we definitely could. I did want to ask, though, before we move on.
Sorry.
So say you notice someone having a stroke, you call 911. Is there anything else you can do for that person while you wait for help to arrive?
So the biggest things that you're going to do is you're going to stay with the patient. You're going to figure out when the last time they were known well. We have to know that. Treatment and the timing is based on when they were last known well. A lot of people wake up with strokes in the morning. Well, we have no idea when during their sleep that happened, so it's when they went to bed and they were normal. Or they woke up in the middle of the night and they were normal at 3 o'clock, but at 6 o'clock when they got out of bed, they couldn't. And so that's very important for us on how we determine how we're going to treat. The next thing is don't give them anything to eat or drink because they're at high risk for aspirating that into their lungs if they've had a stroke. because that swallowing can be affected. And then, being as clear as you can with 911, your address, your callback number, the age, when those symptoms started, and helping that process be as quick as possible. If they're on medications, having those medications right there so that they can take them with them and understand all of those things that they have. Those are kind of the most important things as you're waiting.
And to just remaining calm and trying to help the person stay calm as well. Because it can be pretty scary when you can't speak or you can't move. So trying to stay calm helps as well. But it's kind of hard.
So what are risk factors of stroke?
So there's many, and some of those are things that you can affect, lifestyle things like that you can change, and some of those are things that you can't change. And so we'll kind of go through those. And so we'll start with the ones you can't change, right? Age. We all just get older. We haven't figured out the fountain of youth yet, so we're there. Race. Races can be a factor. In African Americans, they have a higher risk for stroke.
So Hispanics.
And Hispanics. So you can't change that. Gender. Your birth sex in this world is going to be determinate and increase your risk. Males have a higher risk. Women actually have worse outcomes. Heredity and genetics. So family history. If it's part of your genetics, it's part of your genetics. You can't change that. And prior history of strokes. Now, there's lots of things we can change that are also part of that. I'm going to start with obesity because obesity contributes to a lot of the other risk factors that we're going to talk about. Okay, and society during my lifetime has gone from it was pretty rare to now it's more common than it's not. And with obesity can come high blood pressure, heart disease, diabetes is a huge one, smoking, birth control pills. And we'll talk about some of the myths in a minute, but one of those myths is that strokes only happen to older people. I can tell you, Anna and I have taken care of a whole lot of females in their 20s and 30s and early 40s that had strokes that were on birth control. History of the transient ischemic attack or the mini stroke, high cholesterol, some blood disorders where you have like a high red blood cell count, which then, you have more of a risk of those clots. Lack of exercise, excessive alcohol use, illegal drug use, abnormal heart rhythms. So you may have heard of atrial fibrillation. Many of you have smartwatches, and it detects that and tells you, hey, you're in atrial fibrillation. That's a huge risk factor. And then cardiac structural abnormalities. Now, that's something that people are born with, and I can't remember the exact percentage, 20%, I believe, of people have what's called an atrial septal defect, a ventricular septal defect. In between the atrium and or between the two ventricles or the atriums, there's a little hole there. So that hole usually closes after birth. You have to have that when you're inside your mom, because that's what allows the blood to circulate and things like that. And then after birth, that generally closes. Well, there's a large percentage of people where that doesn't close, and that's actually a high risk factor. But that's also something we can fix once we find it or know about it.
Wow, that is impressive. There's a lot more research that I never knew about concerning strokes. That's fascinating to hear about.
And to see how connected, like, heart and the brain are, which makes sense because the oxygen's pumping throughout your body, which goes to your brain. Well, yeah.
Yep.
Yes. Correct me if I'm wrong there, obviously. But so like taking care of your heart takes care of your brain.
Because the risk factors are the same
for heart attack
Yep.
or
and
stroke. They're very similar.
Yes.
Yeah.
And with stroke, blood pressure is like the number one cause of stroke. So with ischemic strokes, if we can control our risk factors, we can decrease the possibility of another stroke. But blood pressure is like a big risk that we need to kind of pay attention to. And a lot of people don't even know that their blood pressure is high until they go in and get checked. So monitoring blood pressures is really important. And if it's high, like the top number over 120 or the bottom number over 80, talk to their provider so they can get that under control.
Earlier you mentioned that it's important, like obviously timing is very important, and it's important to know when the symptoms started showing up. So can you tell us a little bit more about treatments for stroke and how getting treatment faster can help people?
Absolutely. So one of the first things people need to know that is going to tell you how important this is that every minute that goes by after that blood vessel's broke or that blood vessel's been blocked off, you lose approximately 2 million brain cells. Now, I can't afford to lose 2 million brain cells. And so,
I don't think any of us can.
so that's pretty important. The other thing is the first treatment option that we have is thrombolytics, and that is a clot-busting drug. So we push that in there, and it goes up to where the blood clot is, and it breaks it up. Okay, we can only use that up to 4.5 hours, and then after that, the risk factors, the efficacy, and all of that decrease so much that we don't do it after 4.5 hours. Then, if you have what's called a large vessel occlusion, so that is the whole carotid artery on one side branches and feeds your brain. If there's a clot in one of those main branches of that artery or the whole artery itself, there's a treatment where they can go in the interventional radiology lab, and they can thread a catheter all the way up into there, and they can either pull that clot out, or they can take the same thrombolytic medicine and drip it right onto the clot and break it up. And you can go up to 24 hours, but we prefer to treat them in 6 hours. And as you can imagine, if we're losing that many brain cells a minute, the faster you treat them, the better the outcome for the patient's going to be.
I'm assuming that affects recovery too, right? Because depending on how long someone was having the stroke is affecting how many brain cells are dying. And then how does that look for recovery? Like, what's kind of the scale of like got there super fast versus didn't, and what recovery looks like for that scale and range of people?
So the recovery after a stroke, usually if we do treat them soon, there's a better chance of them regaining most of their function back. Like Jim said, the longer we wait, the longer those brain cells go without oxygen, our symptoms can get worse. Or if we're out of the window, we can't fix those symptoms. So the person might always have that, right-sided weakness. Or so those all kind of affect recovery. Usually when people do get treatment sooner, and we minimize all that damage that can happen, sometimes recovery and rehabilitation is a lot easier because of the sooner treatment. So yeah.
And recovery, the length of it, can span a whole wide range. Sometimes if we treat them, their symptoms go away and they walk out of the hospital and they're completely fine and they're recovered. Other times, you may have to go to a skilled nursing facility or a stroke recovery place where you have intensive physical therapy, occupational therapy, and speech therapy, and the recovery can take years. So one of the physicians that comes to our stroke support group all of the time is actually a stroke survivor, and he had a large vessel occlusion, and it affected him, and he still has some speech difficulties to this day, but over the years, he's improved that so much because initially he couldn't talk at all.
And he had the right side paralysis as well.
Yeah.
So he's just worked really hard with the therapies and exercise and getting his functions back.